Hey everyone, and welcome. Today, we are diving deep into a test that's been around for about 100 years, but is still, believe it or not, a cornerstone of modern medicine. The erythrocyte sedimentation rate, or as we all know it, the ESR. It's a surprisingly simple test that can tell us a whole lot about what's going on inside a patient's body. So let's break down exactly how it works.
So, at its core, the concept is incredibly straightforward. You take a sample of blood, you make sure it won't clot, you put it in a skinny vertical tube, and then you just let it sit. After exactly 1 hour, you measure how far down those red blood cells have sunk. That distance, in millimeters, is your ESR. That's it. It's a pure physical measurement.
But hang on, what does measuring falling blood cells really tell you about a patient's health? I mean, how does this simple observation become such a powerful, even though it's non-specific, marker for things like inflammation, infection, or even cancer? Well, that's the real question we're here to answer.
To really get the full picture, here's our game plan. We're going to start with the core science, the physics behind why red cells fall in the first place. Then we'll pop over to the lab to see how the test is actually done. We'll also cover the absolutely critical technical errors that can completely throw off your results. And finally, we'll tie it all together to see how the ESR is used in day-to-day clinical practice.
Okay, so let's jump right into the fundamental science. Before you can even think about interpreting an ESR result, you've got to understand the forces at play inside that little tube. It's basically a battle between what's pushing red cells apart and what's pulling them together.
So, in a healthy person, your red blood cells are just floating around, minding their own business. And the reason for that is a cool concept called zeta potential. You can think of it like a personal force field. Every single red blood cell has this negative charge on its surface, and because like charges repel, they're constantly pushing each other away. This is what keeps them from clumping up.
Now, this is where it gets really interesting. When your body senses inflammation or some kind of tissue injury, the liver starts churning out these things called acute phase proteins, especially this big, sticky one called fibrinogen. Now, these proteins are positively charged, and they just swarm the red blood cells, neutralizing that negative force field. All of a sudden, without that repulsion, the cells start sticking together. They form these long stacks that look just like a roll of coins, and this formation is called rouleau. From there, it's just simple physics. These heavy stacks are way denser and fall through the plasma much faster than a single cell ever could. That right there is the key to why an ESR goes up.
So it's not just about fibrinogen. Other things can mess with the ESR. On the one hand, stuff like high globulins or cholesterol can also increase it. But on the other hand, a protein like albumin can actually decrease it. Now, take a look at the red cell factors. Anemia can, kind of weirdly, increase the ESR. Why? Well, with fewer cells, there's a higher concentration of all those sticky plasma proteins relative to the cells, which promotes that clumping. But what's really important for you to remember in clinical practice is the cell shape. Abnormally shaped cells, like you see in sickle cell disease or spherocytosis, just can't form those neat rouleau stacks. And this means a patient could have some serious inflammation going on, but their ESR might be falsely low or even normal. And that is a huge clinical pitfall you need to be aware of. You know, that 1-hour test isn't just a steady, constant drop. It actually happens in 3 distinct stages. For the first 10 minutes or so, you have the phase of aggregation. That's when the rouleaux are just starting to form. The next 40 minutes, well, that's the main event. It's the phase of settling, where those stacks are falling at a constant, fast rate. And then, in the final 10 minutes, as the cells start piling up at the bottom of the tube, the whole process slows way down in what we call the phase of packing.
Okay, so now that we've got the why down, let's get into the how. How do we actually perform this test in the laboratory?
There are a few different ways to measure ESR. There's the older Wintrobe's method, and even micromethods for when you only have tiny samples, like from pediatric patients. And of course, many modern labs use automated systems now. But the classic method, the one that's still considered the gold standard, is the Westergren method.
Let's walk through the classic Westergren procedure. First, you've got to prepare the sample by mixing blood with a sodium citrate anticoagulant in a super-specific 4:1 ratio. Next, you draw that mixture up into a long, thin pipette right to the 0 mark. Then comes the most critical part. You place that pipette perfectly upright in a special rack and you leave it completely undisturbed for exactly 60 minutes. When that hour is up, you simply read the distance in millimeters from the top of the clear plasma down to the top of the settled red cells. And boom, that's your result.
So, how does that Westergren pipette stack up against the older Wintrobe tube? Well, the most obvious difference is the length. The Westergren is much longer at 30 centimeters, which is really important because it means it can accurately measure very high ESRs. The Winthrop tube is shorter and it's closed at one end, which makes it less sensitive for those high values. Its main perk was that you could also use it to measure packed cell volume, but for ESR, the Westergren is definitely the superior method. Okay, let's talk about something that is absolutely critical for anyone working in a lab: errors. Because the ESR is a physical measurement, not a chemical one, it is incredibly sensitive to technical mistakes. If you get one of these wrong, you could report a result that is completely misleading for the clinical team.
Just look at all the ways this can go sideways. If a tube is tilted by just 3 degrees, it can falsely raise the ESR by 30%. That's insane. If you have air bubbles, they'll literally block the cells from falling. The temperature has to be just right. If it's too warm, the reaction speeds up. Even vibrations from a nearby centrifuge can artificially shake those cells down faster. And of course, the timing has to be exact. Any single one of these can completely invalidate the test result.
All right, this is where it all comes together. We know the science, we know the methods, and we know the pitfalls. Now let's talk about what the results actually mean for a patient.
First things first, there is no single normal ESR. As you can see here, the reference range changes pretty significantly with age, and it's different for men and women. In general, the ESR tends to slowly creep up as we get older. A value of 10 might be totally normal for a young man, but a value of 35 could be perfectly fine for an elderly woman. Context is everything.
So clinically, the ESR really plays two main roles. First, it's a diagnostic clue. Now, it's a non-specific test, which means it won't tell you exactly what's wrong, but a high ESR is basically screaming that something inflammatory is happening in the body. It's especially useful when doctors suspect conditions like temporal arteritis. Its second, and probably more common role, is for monitoring. If you have a patient with a known chronic disease like rheumatoid arthritis, you can track their ESR over time. A falling ESR is a fantastic sign that your treatment is working.
And here's a quick clinical pearl for you. If you ever see an ESR greater than 100 millimeters per hour, your differential diagnosis should narrow down significantly. I mean, while infection and cancer are always possibilities, an extremely high value like this should make you strongly consider conditions like temporal arteritis, polymyalgia rheumatica, or multiple myeloma.
Now, it's not just a high ESR that matters. A very low result can also give you some important clues. Like we talked about, conditions with funky-shaped red cells, like sickle cell anemia, will give you a low reading because rouleau just can't form. A really high red cell count or polycythemia will also slow things down. And interestingly enough, congestive heart failure is also known to be associated with a low ESR, most likely due to changes in those plasma proteins.
And this all brings us to the final and maybe the most important question. In an age of high-tech genetic and molecular tests, why do we still rely on this simple, century-old measurement of falling red blood cells? Well, the answer is that sometimes a broad, integrated picture of systemic inflammation is more clinically useful than any single specific marker. It's a testament to the enduring power of simple, elegant tests in medicine. Thanks for joining me on this explainer.